عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. We'll discuss today skin and subcutaneous tissue lesions, an important topic in surgery. At first, we must know the surgical anatomy of the skin. Skin is formed of three layers: epidermis, dermis, and hypodermis, which is actually the subcutaneous fatty tissue. The epidermis is formed of multiple layers: stratum corneum, which is a horny layer, dead skin cells, stratum lucidum, and stratum granulosum, stratum spinosum, and stratum basalis. Stratum meaning a layer. So the skin epidermis is formed of stratified squamous epithelium. This stratified squamous epithelium is formed of multiple layers, mainly the base layer, very important for us in surgery, and the dermis is formed of two layers: the biliary layer, which is in pink color, and reticular layer. This dermis containing the nerve endings, the capillary, the sweat glands, sebaceous glands, and the subcutaneous tissues, which is formed of fat. So we have the three layers of the skin. Actually, there are two layers: epidermis, which is formed of stratified squamous epithelium. This stratified squamous epithelium is formed of multiple layers, mainly the basal layer, which is a columnar epithelium, and then the dermis, which is formed of mainly two parts: the biliary dermis and reticular dermis. The biliary dermis in the pink color in this photo, and the reticular dermis, they containing the nerve endings, the capillaries, sweat glands, sebaceous glands, and the blood vessels of the skin. And then the hypodermis, which is subcutaneous fatty tissue. You must know the anatomy of the skin to imagine the diseases which can occur in this tissue. At first, we will discuss the cysts of skin and subcutaneous tissues. There is multiple lesions which can occur in the skin and subcutaneous tissues, like inflammation like abscess, carbuncle, and whatever. This is the inflammation, cellulitis, inflammation of the skin and subcutaneous tissue, and this is discussed in the section of infection. We discuss today, inshallah, the cysts of the skin and subcutaneous tissues. We start with the sebaceous cyst. Sebaceous cyst is a cyst which is formed of the sebaceous glands. Sebaceous glands which secrete an oily material on the skin, have an opening on the skin, and the gland secrete the sebum, which is an oily material secreted in the skin. This oil material may be insissated, become solid, and close the opening of the sebaceous gland. And sebaceous gland present secretions, enlarge and form a cyst containing the sebum, which is secreted by the sebaceous gland, forming what's called sebaceous cyst. The characteristic of the sebaceous cyst is the punctum, the opening of the duct of the gland which is closed. This punctum has a characteristic black opening. This black opening which forms the blackheads which occur at the nose in people who have an oily skin. The punctum is a pathognomonic for the sebaceous cyst. How to diagnose a sebaceous cyst? Subcutaneous mass. This mass is cystic lesion. How to differentiate between cystic and solid lesions? By Ross fluctuation test. This is a clinical lesson. So, and the punctum. If a cystic lesion have a punctum opening like this picture. So the punctum, the black head, is a pathognomonic for the sebaceous cyst. What are the complications of sebaceous cyst? Sebaceous cyst may be infected, which is a common complication of the sebaceous cyst forming an abscess, and this abscess may rupture, leading to ulceration, like in this picture, ulceration of the sebaceous cyst. As we see the sebaceous cyst here in the scalp, which is a common site of the sebaceous cyst. Sebaceous cyst occurs in the scalp, scrotum, and the back. Mainly, can occur in any part of the body except the palm and the sole. The palm and the sole are devoid of the sebaceous glands, have no sebaceous glands, so sebaceous cyst can't occur in the palm and the sole. Returning to complications of the sebaceous cyst, first complication is infection, which is a common complication, formation of an abscess, and the patient is presented to you by abscess characteristics, which are redness, hotness, fever, proxia, headache, malaise, etc. The complications of the sebaceous cyst is rupture of this abscess, of this infection, erosion of the skin, and formation, ulceration of the skin. Rupture and ulceration is a common complication of the sebaceous cyst, especially on the scalp. The third complication is sebaceous horn. It is a very rare complication which can occur in the sebaceous cyst, formation of a horn. This horn is formed of the sebum, and this photo is a classic surgical photo which was on the cover of Belly and Love, which is a classic textbook of surgery for undergraduate students. Belly and Love, the very famous and very classic textbook. This photo was the cover of the first edition of the this book, Belly and Love. Sebaceous horn, excretion of the sebum. The sebum is insipid, formation of a horn, like in this picture, which is a rare complication nowadays for the sebaceous cyst. Another photo for a sebaceous horn. Insipid sebum form a horn-like projection in the scalp. Other complication is alopecia, loss of the hair around the cyst, especially that the sebaceous cyst is common in the scalp. Lastly, malignant transformation. Malignant transformation is a very, very rare complication of the sebaceous cyst. How to diagnose a sebaceous cyst? Cystic lesion have a punctum. What are the complications? Infection. This infection may rupture, leading to ulceration, losing of the skin over, and sebaceous horn, malignant transformation. What's the treatment of the sebaceous cyst? Surgical excision. But we must consider removal of the punctum during the surgical excision, because if we don't remove the punctum, recurrence is a rule. So you must remove the cyst with the punctum to avoid recurrence. In the case of complication like an infected cyst, just drainage of the infection and later on removal of the cyst. This is the first cystic lesion. It is a common, very common in the surgical practice to see the sebaceous cyst. We must know the cyst containing a punctum is sebaceous cyst. The second cyst, which is less common than a sebaceous cyst, is the dermoid cyst. The dermoid cyst is a cystic lesion lined by stratified squamous epithelium containing dermal structures, hence its name is derived from containing a dermal. The dermal structures. What are the dermal structures? Hair follicles, sweat glands, nerves, eggs, and whatever. We have four types of the dermoid cyst: sequestration dermoid cyst, which occur at the fusion lines. Sequestration dermoid cyst, which occur at the fusion lines. We know as in embryology, there is a fusion lines in the embryo. This fusion lines, when they fuse with each other, they may include a part of the skin between this infusion lines, so form the dermoid cyst, which increases with the age. It's for the most common site of this infusion lines is external angular dermoid. External angular dermoid, which occur at the external angle of the eye, like the upper photo. This is the external angular dermoid, which is the common site of the dermoid cyst. The commonest site at all is the external angular dermoid. This is another photo, external angular dermoid, which occur at the external angle of the eye, the commonest site. The root of the nose, which is called internal angular dermoids, occur at the root of the nose at the internal angle, which is internal angular dermoid, around the ear, which is a preauricular dermoid cyst. Midline, at the fusion line, midline, and never occur in the limbs. There is no fusion line in the limbs. The first is sequestration dermoid cyst. Sequestration dermoid occur at the fusion lines, the midline. External angular dermoid, which is the commonest site. Internal angular dermoid at the root of the nose, and periauricular. This is the common sites of the dermoid cyst. Dermoid cyst again is a cyst lined by stratified squamous epithelium containing dermal structures, hence its name dermoid. Sequestration dermoid, during fusion lines in the embryo, they may include a part of the skin. This part of the skin proliferate and grow, and they appear later on the life as a sequestration dermoid cyst. What's the clinical presentation of sequestration dermoid cyst? It is hemispherical, like cystic swelling with a smooth surface. The sequestration dermoid, it's congenital in origin but appear later in life, not dated since birth. Tubular dermoid cyst, which is the second type of the dermoid cyst, like thyroglossal cyst. Thyroglossal cyst is a type of a dermoid cyst, which is tubulodermoid. The branchial cyst, which occur from the cervical sinus, will be taken in the next chapter. Tubulodermoid cyst, like thyroglossal cyst. Thyroglossal cyst is a type of dermoid cyst, which is a tubulodermoid cyst. The third type of dermoid cyst is implantation dermoid. Implantation dermoid occurs at the fingers, like in barbers, in the palm, puncture in the skin of the palm of the fingers, implantation of part of the skin in this puncture and healing over it, proliferation of the implanted skin, leading to formation of the dermal cyst or dermoid cyst, common in manual workers like barbers. Lastly, the teratodermoid cyst. Teratodermoid cyst is a benign tumor, which is called benign teratoma. It occurs at the ovaries, testes, and sacrococcygeal region and posterior mediastinum. The commonest site of the teratodermoid is the ovaries. The ovaries is a cystic lesion, containing hair, tooth, bone, cartilage, or glands. They are derived from the three embryonic layers: mesoderm, endoderm, and ectoderm. Mesoderm, endoderm, and ectoderm. The treatment of all dermoid cysts is surgical excision. Again, the remote cyst is the cyst which is lined by stratified squamous epithelium containing the dermal structures. We have 4 types: sequestration dermoid, which occur as a fusion lines. The common structure is external angular dermoid, as we see in the pictures, and tubulodermoid like thyroglossal cyst or branchial cyst. The third type is the implantation dermoid, which occur at the palm or the sole in the manual workers due to implantation of the skin due to puncture of in the fingers, implantation of the skin at this puncture and proliferation formation of a cyst. Lastly, teratodermoid, which is a benign tumor containing the hair follicles, teeth, cartilage, bone, and this is teratodermoid cyst is derived from the 3 embryonic layers: ectoderm, endoderm, and the mesoderm. The common site is the ovary, but it can occur at testis, posterior mediastinum, and sacrococcygeal region. The treatment of all types of dermoid cyst is surgical excision. One of the cystic lesions of the skin is haemangiomas, strawberry haemangiomas, or strawberry nevus, which is the commonest type of the haemangiomas, commonly occur at the face. It's called a birthmark. The birthmark of strawberry haemangioma. The strawberry haemangioma is red mass of capillaries lined by embryonic epithelium, like picture on the left side. This is strawberry haemangioma, or birthmark. It's slightly elevated over the skin, appear shortly after birth, 1 to 3 weeks. It's will disappear within 8 years and may regress. If not disappear, the treatment may be corticosteroid, prednisone, one of the drugs which give a good results, Androl, propranolol, local corticosteroid injection in resistant cases, surgical excision with plastic reconstruction. The second haemangioma is the Salomon patch. Salomon patch is a birthmark which occurs at the forehead and the face, like this baby on the right side, and disappear at 1 year. Salomon patch. The haemangiomas, 2 types: strawberry haemangioma, strawberry or birthmark. Strawberry haemangioma, the capillaries, mass of the capillaries elevated over the skin and disappear within 8 years. If it doesn't disappear, we may use prednisone, propranolol, injection of prednisone, or surgical excision. Salomon patch occur at the birth, at the forehead, and or the occipital, and disappear at 1 year age. We have vascular malformations. Vascular malformations, the first is port wine stain. Port wine stain occurs at the face and follow the distribution of the 5th cranial nerve, the trigeminal nerve. The distribution of the 5th cranial, like in this picture, this is the distribution of the trigeminal nerve or 5th cranial nerve. The distribution of this nerve, the port wine stain occur. Port is derived from Portugal, wine is derived from wine. Port wine stain is derived from Portugal wine. Portugal wine is the الخمرة wine الخمر Portugal. الخمرة البرتغالية أو الخمرة البرتغالية, port wine, which have the same color of the port wine stain. Port wine stain is formed of dilated capillaries lined with adult endothelium. It's dated since birth, have a stationary course, doesn't regress, develop with the patient, doesn't elevate it over the surface. The treatment is very difficult, maybe laser ablation, but the results are disappointing. The second vascular malformation is Campbell-De Morgan's. Campbell-De Morgan spot, which occur mainly in the abdomen and the chest, bright red spots. These bright red spots have linked with internal malignancy. In the past, they suppose that it's linked with internal malignancy, but not proof that everyone have brought to Campbell-De Morgan spots have an internal malignancy. It's no treatment. Osler nodule is a vascular malformation. This vascular malformation is called hereditary hemorrhagic telangiectasia. Occurs at the skin or over the mucous membranes, like in the esophagus or in the stomach or the anal canal, on the GIT, leading to bleeding from the GIT. Usually it presents by unexplained anemia, bleeding from the GIT leading to unexplained anemia. Osler's nodules is treated by endoscopic coagulation of the bleeding haemangioma in the GIT or surgical excision if it's a skin, surgical excision of the skin. Spider nevi. The spider nevi, the skin occur in the skin drained by the superior vena cava. It's our dilated arterioles with central zone. They appear in the patients with liver failure. Dilated arteries or arterioles which occur in the liver failure patients due to high estrogen level and the vasoactive substances which lead to dilatation of these arterioles. No treatment, only control of the liver cell failure. Venous malformation. The last is arterial malformations or capillary malformation. Port wine stain, this was derived from Portugal wine. Campbell-De Morgan, Osler's nodule, spiral nevi, all are arterial vascular malformations. We have the venous malformations or the cavernous haemangioma, which is in the old name. The cavernous haemangioma occur at the cheeks, mainly at the lip, like in the picture, leading to macrocelia, increasing the size of the lips, or in the tongue, macroglossia, or even in the internal organs, like the picture of this CT. This is a CT scan showing liver with a venous hemangioma, a venous malformation, which is a cavernous hemangioma. Cavernous hemangioma is formed of dilated venous spaces connected with the general circulation containing blood. The venous malformation or a cavernous hemangioma is a dilated veins with pools of the blood, and this is connected to the general circulation. It's a compressible swelling, lobulated surface, mainly to bleeding, internal or external bleeding, and increases in size without involution. The treatment is injection sclerotherapy or intravascular injection of a mass or gel foam. Gel foam, a mass, include the vessel which feed this venous malformation, or surgical excision, which is a very difficult thing, surgical excision. Arterial malformation, or arterial hemangioma, cirrhoid aneurysm. This is another picture, CT picture of venous hemangioma or venous malformation or cavernous hemangioma in the liver. Arterial malformation or cirrhoid aneurysm. Cirrhoid aneurysm is derived from a snake. Cirrhoid derived from the snake, commonest site in the temporal region, occurs in the superficial temporal vessels, mainly site or occipital region. The patient has a large compressible pulsating mass in the temporal side of the head. This mass has an audible bruit. There is an underlying skull defect in the plain X-ray. Angiography shows the feeding vessels, ligation of the vessel, or excision, or embolization by a gel foam. Gel foam is a mass closing the feeding vessel. This is the arterial malformation or cirrhoid aneurysm. Lastly, we have the true vascular tumors like a glomus tumor. What's the glomus tumor? Glomus tumor, it's a true benign tumor rising from the glomus body. The glomus body is a vascular body which present at the extremities and at the ear. This is glomus body is related to temperature regarding the body and temperature equalization in the body. It's composed of arterioles and venules and sympathetic nerves. Tumor, benign tumor of this glomus body leading to severe pain. It's usually below the nail, under the nail, splotch discoloration. Under the nail is the glomus body, but may occur in the ear also. It's composed of vascular, neural, smooth muscle fibers, haemangioma, very small tender spot under the nail. Treatment is surgical excision. True vascular tumors like hemangiosarcoma or Kaposi sarcoma, which occur in the AIDS patients. Lymphangiomas. Lymphangiomas, we have a capillary lymphangioma, like a capillary hemangiomas, and cavernous lymphangioma, and lastly, the cystic hygroma. The capillary lymphangioma is the skin dilated lymphatics capillaries, but it's a lymphatic capillaries, capillary lymphangioma. It's occurs at the skin and mucous membrane, especially the tongue, like this picture, and may occur at the skin, like this picture, brownish in color, papules at the skin on the mucous membrane, brownish in color, brownish papules at the mucous membrane and the skin. Treatment is surgical excision if accessible. This is the capillary lymphangioma. Cystic hygroma. Cystic hygroma is a lymphatic malformation which occur at the neck of the baby. It may be too difficult birth and may need to section, cesarean section for delivery. This is the first presentation of the cystic hygroma, be detected intrauterine by 4D ultrasound. The characteristic of cystic hygroma is brilliant translucent swelling. Brilliant translucent swelling. What's the meaning of brilliant translucent swelling? It's transparent. If I put a torch over it, light will be transparent. This is the diagnostic for cystic hygroma. What's the treatment of cystic hygroma? Surgical excision. Right, for revision, rapid revision, we have a vascular malformations and the vascular cysts of the skin. We have arterial, venous, and capillary. Capillary hemangioma, capillary hemangioma or hemangioma simplex or capusiform hemangioenthelioma. الكابيلاري هيمانجيوما او البيرث مارك اللي هي strawberry color like the strawberry to occur at the birth. Regression with the age is the rule. Vascular malformations, capillary vascular malformations. The first is a port wine stain. Port wine stain is a patch which occur at the trigeminal nerve distribution. We must know it occur at the trigeminal nerve distribution. Campbell de Morgan spots, which is supposed to be related to internal malignancy, but not proved. Osler's nodule, Osler nodules usually occur at the GIT, leading to unexplained anemia and bleeding. Spider nevi occur in liver failure, patients in the superior vena cava distribution, dilated arterioles due to estrogen and vasoactive substances. This is the capillary malformations. Venous malformation, cavernous haemangioma is the most common, to occur at the lip or the mouth cheek leading to macrocelia, or the tongue leading to macroglossia. Occur at internal organs like liver, which is common, cavernous haemangioma in the liver, as we see in the CT scan. The treatment is sclerotherapy, ligation of the feeding vessel, or surgical excision, which is difficult. Arterial malformation, dilated arteries, like in the temporal region, superficial temporal artery, leading to cercoid aneurysm. Cercoid aneurysm, like the snake, dilated compressible artery with pulsations at the temporal region, and the leg bone is erosed, and there is a severe headache in these patients. The treatment is ligation of the feeding vessel or obstruction or embolization by the diaphragm. It's arterial malformations. The true tumors of vascular tumor, the most common is glomus tumor, which occur at the glomus body. This glomus body, the tips of the finger and the ear, and responsible for the temperature. It's formed of arteries, veins, nerves, sympathetic nerves, so it's due to severe pain. The treatment is surgical excision. Lymphangiomas, we have capillary lymphangioma, cavernous lymphangioma, and the cystic hygroma. Cystic hygroma is a form of the cavernous lymphangiomas. Capillary lymphangioma occur in the skin or in the tongue, leading to macroglossia. It's a brownish papule. The treatment is surgical excision. Cystic hygroma occur at the neck of the baby, leading to difficult labor, and we need to for cesarean section. The characteristic of cystic hygroma is brilliant translucent swelling. The treatment is surgical excision. This is the vascular malformation, vascular and lymphatics malformation, which is the formation of the cysts in the skin. So we have the cysts of the skin, sebaceous cyst, dermoid cyst, and vascular malformations. Sebaceous cyst, dermoid cyst, and vascular malformations. They are the types of the cystic lesions appear on the skin. After discussing the cysts of the skin and subcutaneous tissues, we will discuss now, inshallah, the neoplasms of the skin and subcutaneous tissues, and we start with the benign lesions. Papilloma is the most common benign lesion. It may be single or multiple, pedunculated, vascular connective tissue core covered by epithelium. Connective tissue core covered by epithelium caused by human papilloma virus. May turn malignant, but in special sites like the inner canal, especially human papilloma virus type 16 and type 18, which occur lead to formation of a wart like projections in the skin of the anal canal, which is turned to squamous cell carcinoma of the anal canal. Treatment of papilloma is surgical excision. Benign melanomas of the skin. The benign melanoma of the skin, we have 5 types of benign melanomas. Benign melanoma or pigmented nevus, or the mole. We have 5 types of benign melanomas. The first is the simple nevus. The simple nevus is the commonest nevus which occur in every population. The melanocytes, which is responsible for the color of the skin, are condensed at the site. They are condensed in the simple melanoma in the dermis. Condensation of the melanocytes at the epidermis of the skin. We remember the layers of the skin: epidermis, which is formed of multiple layers, stratified squamous epithelium. The most important is the basal layer, and then the dermis, which have two layers, papillary and reticular layer, returning to the first slide. So the simple intradermal nevus condensation of the melanocytes at the dermis. This is the simple nevus, which occur in every population. It can occur at any site of the body except the palm with stools and genitalia. Except the palm with stool and genitalia. It may contain hair, but never to turn malignant. This is the simple nevus. Junctional nevus. Junctional nevus is another type of the benign melanomas. It's different from the simple nevus. The melanocytes, as we see in this picture, are condensed at the basal layer of the epidermis. The basal layer of the epidermis, this brown discoloration is the condensation of the melanocytes at the basal layer of the epidermis. The basal layer of the epidermis, and may extend to the papillary layer of the dermis, like in this picture. It occurs in genitalia, palm, stool, mucous membrane. Occur at any part of the body, especially genitalia, palm, and stool. It's hairless, which is different from the simple nevus, and may turn malignant. About the difference between simple nevus and the junctional nevus. Simple nevus is a condensation of the melanocytes at the papillary dermis. While the junctional nevus at the basal layer of the epidermis. Simple nevus occur at any site of the body except the palm, stool, genitalia. Junctional nevus occur in every site of the body, and especially palm, stool, genitalia. Simple nevus may contain hair. Junctional nevus doesn't contain hair. Simple nevus doesn't turn malignant. Junctional nevus turn malignant. So we have four differentiation between simple nevus and junctional nevus. The third type is the compound nevus. Compound nevus have the two characteristics of the simple and junctional nevus. The melanocytes, as we see in this picture, in brownish color, are present at the basal layer of the epidermis and in the papillary layer of the dermis. Compound nevus common in the infancy and may be hairy, forming what's called giant hairy nevus, and usually turn malignant. Compound nevus usually turn malignant. Giant hairy nevus, which is usually turn malignant. Again, compound nevus have the two criteria of the simple and the junctional nevus. Melanocytes are present in the dermis with junctional activities present at basal layer of epidermis and in the dermis. It's common in infancy, containing hair, may be extended over the body, especially at the back. Formation of giant hairy nevus turn malignant. Compound nevus turn malignant. The fourth type is the freckles, in Arabic النمش. Freckles أو lentigo. Lentigo is a common presentation in the blonde population, especially red hair population. Freckles are the site where the melanocyte replace all the basal layer of the epidermis. All the basal layer of the epidermis are replaced by the melanocytes. Basal layer of the epidermis, like in the picture of histology, the basal layer of the epidermis is replaced by melanocytes. Freckles occur in population, blonde population, especially redhead population, and has a special type occur at old age population, which is called Hutchinson's freckles. Hutchinson's freckles occur in old population, occur mainly at the face, of the all population and commonly turn malignant. Hutchinson's freckles commonly turn malignant. It's called lentigo malignia. Lentigo malignia, as it's commonly turned malignant. This is the freckles. Last type of benign melanomas اللي هو blue nevus. Blue nevus, the nevus is usually brownish in color. Brown in color, bright brown or light brown or dark brown, but blue nevus is a blue in color. The blue nevus is melanocytes are spindle-shaped melanocytes and present deeply in the dermis. You see at the picture of the histology, the melanocytes are deep in the dermis, not near the epidermis like the other pictures. As we see in this picture or on this picture, melanocytes are near the epidermis. Here, the spindle-shaped melanocytes, spindle-shaped cells melanocytes are deep in the dermis, form the blue nevus. Blue nevus may turn malignant. What's the treatment of moles or benign melanomas? In ugly cases, for cosmetic regions, surgical excision. In suspected cases of malignancy, we must take a biopsy and treat as malignant melanoma, as we will see inshallah in the melanoma lecture. What are the criteria of turning malignancy of the benign moles? Again, we have 5 types of benign melanomas. Simple nevus, the melanocytes are present at the epidermis. Near the epidermis is common in the palm. It's common in every site of the body except the palm, stool, genitalia may contain hair and doesn't turn malignant. Junctional nevus, the melanocytes are condensed at the basal layer of at the site of the basal layer of the epidermis. Junctional nevus occur at any site of the body, especially genitalia, palm, stool, and mucous membranes. It's hairless and may turn malignant. Compound nevus, simple and junctional nevus occur in the infancy, containing hair, may reach a large size, giant hairy nevus, and turn malignant. Freckles and namish, lentigo. It's common in blonde population, especially redhead population. Replacement of the basement membrane of the skin in some sites, like the face, with melanocytes. If occur at old age population, it's called Hutchinson's freckles, and it's turn malignant, lentigo malignia. Lastly, blue nevus. Blue nevus, the melanocytes are spindle-shaped and are present deeply at the dermis, form a blue color nevi. The treatment of melanomas, benign melanomas, excision for osmosis or excision for fear of turning malignancy. This is the common benign skin lesions. We will talk now about a common or very common benign subcutaneous lesion, lipoma. Lipoma is the commonest benign tumor of body. The commonest benign tumor of the body is lipoma, which is a benign tumor rising from the adipose tissue. Is a condensation of adipose tissue, which is usually surrounded by a capsule, benign lesion. So it's surrounded by a true capsule and a false capsule, condensation of the surrounding structures. The lipoma occur at any site of the body. Maybe subcutaneous, subfacial, intramuscular, submucosal, internal in the intestine, it's except the sites which is devoid of adipose tissue like البرين and البينس والبالم والسول. This is the sites which are devoid of subcutaneous tissues. What are the types of lipoma? We have the first type, which is a pure lipoma, as we see in this picture. And this histological picture, aggregation of fat cells. This is the fat cells. The fat cells, and these fat cells are surrounded by a capsule, a true capsule. This is the commonest type, pure lipoma. Pure lipoma, which is the commonest type, is fat aggregation with true capsule and fibrosity between this fat cells, formation of atropically. The second type of the lipoma is fibrolipoma. As we see in this picture, the fat cells, there is a fibrous tissue in between the fat cells. Last type of lipoma is neoplasm. Neoplasm, that's the fat cells with vascular structures in between, leading to make the lipoma is more soft in consistency. The common site is the parotid region, neoplasm. But we have three types of lipomas. Fibrolipoma and pure lipoma and neoplasm. What are the complications of lipoma? Complications of lipoma can be summarized by 2CIA. Number 2, 2C, 2I, and 2M. The first 2C is compression. As we said, that the lipoma can occur at any site of the body have a fat except the brain, but it can occur at the spinal cord, leading to compression of the spinal cord. Compression of the spinal cord leading to paraplegia. It's a fatal complication of one of the major complications of lipoma, which is called subcutaneous lipoma, compression of the spinal cord, the first complication of lipoma. The second C is calcification. Calcification of lipoma is a bad sign and may indicate transformation of lipoma to malignancy, which is the last complication of lipoma. As we see, this lipoma have a white coloration in between, not a yellowish coloration of the fat. Calcification. The third is intestinal complications. Intestinal complications, we have 2I, 2C, and 2M. Intestinal complications, submucosal lipoma leading to interception of the intestine or intestinal obstruction. Interception or intestinal obstruction. This is intestinal complications of lipomas. The second I is infection. Infection of lipoma and ulceration, formation of an abscess is a very rare complication, not a common complication of lipoma. Migration of lipoma. Migration of lipoma. Lipoma is a subcutaneous lesion. May migrate and form a pedicle, become a pedunculated lipoma. Migration. Lastly, malignant transformation, liposarcoma to liposarcoma. So we have 6 complications of lipoma: compression, 2C, compression, calcification, 2I, spinal complications and infection, 2M, migration, and malignant transformation. This is the complications of melanoma. What's the clinical picture of lipoma? When diagnosing a swelling in surgery, as we take in the clinical lessons, we must detect the 8S. The 8S. What are the 8S? First S is solitary or multiple. Usually the lipoma is solitary lesion, single lesion, but it may occur as a multiple lesions. Multiple lipomatosis, like in this picture, occur in certain families. The patient have multiple lipomas in the body. It's called Dercum's disease. The differentiation between the single lipoma and the multiple lipoma, Dercum's disease, is painful, while the single lipoma is usually not painful. At first, the first S is the solitary or multiple. The second is the site. The common site of lipoma is shoulder and leg. Can occur at any site of the body except brain, penis, palm, stool, but it's commonly at the shoulder and the leg. First is solitary or multiple. Second is the site. Third is size. Size of the lipoma is variable. Maybe small size to large lipomas. Size, shape of lipoma, usually oval or irregular in shape. Skin over the lipoma, usually attached to the skin over it by a fibrous strand, leading to lobulated surface of the lipoma. Formation of lobulation of the lipoma. Surrounding structures, it's not attached to the fascia or the muscle. Usually has slippery edges, not attached to the surrounding structures. Special character has a slippery edges. Slippery edges because the lipoma move between the true capsule and the false capsule. Movement of the lipoma between the true and false capsule, giving the characteristic slippery edges. So the 8S is solitary or multiple, usually solitary, but maybe multiple. Site at any site of the body, especially the back and the shoulder. Size variable in size, shape oval or irregular in shape, surface lobulated surface due to fibrous strand attached to the skin. Surrounding structures not attached to the surrounding structures have a slippery edges due to movement between the true capsule and the false capsule. Lastly, this is the lobulated surface of the lipoma due to fibrous strands. Lastly, the consistency of the lipoma. Lipoma is pseudo-fluctuant. What's the meaning of pseudo-fluctuant? We know that the differentiation between the cystic lesions and the solid lesion in the body, surgery in general, we do what's called fluctuation test. Fluctuation test differentiate between the solid lesions and the cystic lesions. Cystic lesions have a fluid which move inside the cyst, leading to fluctuation. Lipoma is actually a solid lesion, not a cystic lesion, but it gives a picture of fluctuation. Give the picture of fluid movement inside a sac, but it's not actually a fluid, it's a fat, because the fat is very soft, giving the picture of the fluid movement. So it's called pseudo, and not true fluctuation. Pseudo fluctuation. We have three criteria important in the lipoma. It's a lobulated surface due to fibrous strands, like in this picture of parotid lipoma, and slippery edges, movement between the true capsule and false capsule. Lastly, pseudo fluctuation. The pathognomonic for lipoma is lobulated surface. Pathognomonic of the lipoma is lobulated surface. But the main three criteria of the lipoma for diagnosis is slippery edges, pseudo fluctuation, lobulated surface. we must differentiate lipoma from the sebaceous cyst. Sebaceous cyst have a punctum. This is the most common two lesions of skin and subcutaneous tissues. If you want to talk a whole message, the common lesions of the skin and subcutaneous tissue is the lipoma and the sebaceous cyst. How to differentiate? Sebaceous cyst has a punctum. Lipoma has a slippery edges, pseudofluctuation, and lobulated surface. Thank you.